Thank you so much. Welcome to everybody. It's a real pleasure to see you here at the 2024 Nuffield Summit. So thank you so much for joining. My name is Martin Marshall. I'm chair of the Nuffield Trust. And as setting the context, if you like, I want to take you back 25 years to the late 1990s. This is a time that some of you will remember the NHS was also struggling, in crisis, long waiting lists. And the government at the time, after a little bit of encouragement, intervened big time. And in a relatively short period of time, just a few years, turned the NHS round to the point where the Commonwealth Fund surveys, the annual ratings of healthcare systems, rated the NHS as the top performing or one of the top performing healthcare systems in the world for a period of 8 or 9 years. So what did the government do? They did three things, essentially. Number one, they invested money, lots of money, actually. In retrospect, too much money, more than the NHS could cope with. But the idea of too much money feels quite good at the moment, doesn't it? The second thing that they did was had a very clear strategy and a very clear plan. And the third thing they did was relentlessly focus on implementation. And those of you who haven't read Michael Barber's book, Instruction to Deliver, about the implementation plans of the government then in public sector, I really recommend you do so because it's a really fascinating read. So how did they do it? Well, it was mostly target setting and incentives. And of course, we know that works. It works remarkably quickly and remarkably well. We know that changing behaviours using targets and incentives is good. Changing hearts and minds is much more difficult. And I'm not sure those reforms did change hearts and minds, and that's why as soon as the government took their foot off the accelerator, things went backwards. And some people have argued that even if over the last 10 or 15 years we hadn't had austerity, we hadn't had a pandemic, we hadn't had the current economic crisis, that we would still be in not a very good place as the NHS, because we simply don't have a culture that values learning and improvement, or a culture that values collaboration and innovation. So culture is the big issue, it seems to me. And in my role as a non-executive director of my local NHS trust, I talk to frontline staff, and I don't specifically ask them about culture, because culture is such a catch-all, unhelpful phrase, but I say to them, how do you do things around here? What's important to you? What do you value, you and your colleagues? What do you collectively value? Really interesting answers I get back from them. So some of them will say, well, really value supporting each other. We really value working together as a team, collaborating, mentorship. That's what we really value. Other people will say, well, they really value innovation, entrepreneurship. Some people will say, actually, we really value competitiveness. We value being the best. We want to provide the best possible service. We want to be the very best in our fields. So there's a series of kind of cultural attributes there that people describe that they value, that they think is really important. But when I say, okay, so what is the prevailing culture in the environment that you work in at the moment? They say it's a top-down controlling culture, controlling rather than enabling. They say it's much more about checking rather than it is about trusting. So here's my challenge to you for the next couple of days. How do we create a culture that is an enabling culture, a culture that values improvement and values innovation and allows us to move the health and care system forward? So there's my challenge to you. I know we've got a really exciting programme for you to help you to think about these issues. We've got our usual selection of keynotes and panel discussions and some downtime. You might think after a couple of days quite not enough downtime, but some downtime as well to mix with friends and colleagues. We're going to be kicking off in a few minutes with Thea Stein, our Chief Executive. Where's Thea? Thea's there, brilliant. Thea took over from Nigel Edwards 6 months ago. He's done a truly stunning job, not only at maintaining, without a step really, without any backward step at all, maintaining the mission of the Nuffield Trust, which is all about using evidence and analysis in order to facilitate catalysed change. Thea's done that, but she's also brought her own unique background as an NHS manager, a passion for primary and community care, a passion for working across boundaries, particularly with local government, and a real commitment to understanding the disconnect between policy and practice and asking hard questions about that disconnect. So Thea's going to be working with Sam Freeman on the next session, looking at productivity. So that's going to be really exciting. We've also got Secretary of State. I'd like to welcome Secretary of State. She's going to be coming, talking about the government's response to the NHS crisis. We've got Chris Whitty, one of the most courageous professional leaders, who's going to be talking not about COVID, or at least I think probably not about COVID, which is going to be delightful about. He's going to be talking about the changing nature of patterns of disease in frail elderly people. We've got a series of panel discussions on trust, on risk, on uncertainty, on workforce, and on AI. So we've got lots of sessions that I think will be really stimulating. We've also got a couple of sessions from sponsors at lunchtime today. We've got a session from Lilly on wearables and how they can improve independence. That's going to be chaired by Helen Buckingham. It's in the Buckingham Suite, and lunch is provided in the Buckingham Room prior to the Buckingham Suite. So she sounds like part of the aristocracy, which she is, of course. So that'll be a really fun session. And tomorrow morning, we've got a session with our media partners, the BMJ, who are going to be looking at the impact of technology on clinician-patient relationships. We've also got, in the coffee room next door, we've got 4 posters describing some of the work that our staff in the Nuffield are doing, and I really encourage you to go and have a look at those. So very briefly, quick bit of housekeeping. Almost all of the sessions are going to be live streamed and live tweeted. Please join in, hashtag NS Summit, so that you can join in there. We're looking forward to your contributions. There's going to be roving microphones. If you want to speak, just stick up your hand and someone will come to you. Please stand up if you're able and give your name and where you're from, and then ask your question. There's going to be evaluation forms around on the tables. Please do use them so that we can learn and improve. If you've got phones, please turn them to silent, or even better, switch them off. Such a liberating thing to do. And as far as fire alarms are concerned, there's nothing planned, so if something goes off, it's a real McCoy, so please head for the exit. So I'm really grateful to all of you for making the time. We know how busy your lives are. Making the time for a couple of days to have time out and to address some really challenging issues. We all know that the NHS has never been had a deeper crisis as it's in at the moment. The same for social care as well, and particularly the interaction between the two. But it feels like we've got really good building block. We've got an amazing, committed set of staff, and we've got public support, particularly for the values of what we're trying to achieve. And that seems to me to be a firm foundation on which to build. So I'm now going to hand over to Thea and to Sam for the first session on productivity. Thea and Sam, please.
Thanks. Sam just has to sit there now and look really, really interested in every single word I say, because he's then going to talk to me afterwards. So, I'm going to talk about productivity, and I'm going to suggest that we aren't having the most productive conversation that we could be having about such a thing. I know it's a bit of a funny one, but I enjoy that a lot. And when I arrived at the Nuffield, which I did actually 5 months ago, I realised very quickly that I needed to be able to talk about productivity. And some of you in this audience know me quite well. I would know that actually talking about productivity was not something I did a lot of, actually. But I realised really quickly that everyone's talking about productivity. And if I was going to get into a room with a politician anytime soon, my man yesterday, I was going to need to be able to talk really articulately about productivity. I was going to have to be able to be in that room and talk to any politician, anybody in government, and say, I understand it, I see it, and I can tell you what's going on. So I thought, better get my skates on, better start. I realised that my starting point, actually, for being really interested in this, though, was a bit defensive. If you cut me open, you probably still see something inside me that says NHS. I spent 10 years out of the NHS. I was in an economic development agency, I was in charitable work, I did all sorts of things. But really, you cut me open, it says NHS. And some of my desire to get in those rooms with politicians, with others, with people in the commentariat was actually because I'm going to tell you what it's really like, guys. There was a bit of me that came from a defensive place. I need to explain to you what's happening with productivity. A bit of me that was still feeling, you don't really get it, you don't really understand. Myron is a thinker, a leadership thinker, and he's somebody that I've worked with in the past, and I can't see if Rob's here, Rob Webster, he's worked with him a lot with as well. And one of the things he says, you can start somewhere, you can follow it everywhere. It doesn't matter where you start, see where it takes you. So I started with productivity, and started probably from not the best place, which was I'm going to explain this, but from a defensive angle. But I think my own experiences and reflections were really useful. And the more I started looking at it, the more I became really interested in why this debate was so stuck. Why were we having such unproductive conversations about this essential, important, critical issue, productivity? There is an issue. So let's start by being really clear. There is an issue. There's a really interesting issue about productivity. The public have a felt experience that something's happening. Something feels different to them. Staff, though, have a felt experience that they have never worked so hard. And when I say staff, I always mean clinical staff and managerial staff. That everybody feels they have never worked so hard. That somehow we all know that the information we're looking at when we look at information about productivity feels partial, which is why we end up in this space going, but. I've been in so many rooms looking at productivity data over many, many years where I go, well, that's an apple and that's a pear. You don't understand. Why are we in that? But there's something we know. There are genuinely more staff in the NHS. There is genuinely more money. So what is going on? Well, this is going on a lot. This happens a lot. And this is happening a lot. That happens a lot. And that is part of the base reason why we're just really not getting there. Wiser people than me, Julia Unwin, talk about the two lexicons of public policy. The rational lexicon, you can all read for yourself, and the relational lexicon. The relational lexicon, I should be really clear, is not an irrational lexicon. It is relational. Much of the debate about productivity takes place in one lexicon, the rational lexicon. Much of the way we work in the NHS, the way we live in the NHS, is in the relational lexicon. You immediately have an issue. We have huge issue with the language that continues to be the language that frames the productivity debate. It is so old-fashioned. It is also really scientific. When you start to trace it back, and gosh, I've gone down a rabbit hole with this, you see it based in Taylorism, in Fordism. I know people love Toyota and lean manufacturing. I love a lot about it, but we probably don't bring it into the NHS in the right, complete way, and I'll come back to that. I know people in this audience who love Virginia Mason and the use of the word waste, and there are some great things there. But fundamentally, this language, which is still language from scientific management from the 19th century, frames our understanding of this world, which I would argue is relational, and we try and bring in a language that becomes incoherent, doesn't fit. This is how people talk in health and social care. We talk about care, quality, compassion, equity, gold standard, complexity, hard work, moral injury, pride. I could go on and on. These are relational worlds. But what we have is a system which talks to us, or we talk to each other, increasingly in words that are around productivity and scientific language. I don't know if Jennifer's here, paper in the BMJ where Jennifer Dixon and others wrote. She said, and I couldn't put it better, productivity is a subject guaranteed to kill the attention of clinicians, but still we persist. And we do, we persist. Briodi is somebody I'm going to come back to later, is an anthropologist. She still works in America around a whole range of businesses, both public and private. And she said miscommunication occurred between people from the same language or national identity because nobody even notices or questions the assumptions they use. I think this is really important. When we're doing something where I'm going and working internationally, working in China, I know there's a culturally different space. I know I've got to understand that. I know there could be miscommunication. I work incredibly hard to understand that international world and the different cultural worlds we bring. But across health and social care, across government and the front line, we think we're speaking the same language. We think we're doing the same thing. I don't think we are. And the root cause of why we're not having a productive conversation about productivity is there is no psychological safety. Those of you leading your own organizations at the moment, I would hope and imagine that you are providing an umbrella that creates psychological safety in your own space. But I would argue that from Treasury and Minister to DHSC and NHSE to Chief Exec, etc. This is not a world of psychological safety. I'm not going to read what's here, but it is felt permission for candor. I'm sure in this erudite audience you all understand Amy Edmondson's work, and Nigel, in fact, talked about her last year at the summit. It's incredibly important. And her very, very important work on what psychological safety really is and how important it is for all of us. If you do not have the ability to have a psychologically safe conversation, you will never have an honest one. So if my comms team say to me, Thea, I hope your slides are going to be ready by Wednesday, because if they're not ready by Wednesday and we can't upload them, we can't do it, blah, 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 blah. And I go on Wednesday morning, I haven't done them yet. It's only a psychologically safe place, because actually me and Leonora have a good relationship. And I can say, see, the reason I haven't done them is because of X, and this is what's happening. I'm actually struggling with this, and could you help me? And we have a psychologically safe place. But if I'm scared of her, probably if I was wiser, I would be more scared, I'd be saying, well, the thing is, the dog ate my homework. I mean, what can I do? Psychological safety really, really matters. If you can't have candor, you will not have a proper conversation. We've never talked more about employee health or well-being. When I led a trust, we never talked about it more. But do people really believe us? Do people really believe that their health and well-being is at the heart of everything that we're talking about? There's a great project, and I'd recommend anybody to go and look at the Aristotle, not now, don't look at it now, but look at the Aristotle project that Google did. Google did a piece of work looking internationally at all their teams, and they set off asking the question, who are our most productive teams? Really important question. What did they find at the end of a huge piece of international research? They found the teams that were most productive. It wasn't, we've got the best data analyst or the best engineer or this, which is what they thought they were looking at. It was the teams that got on best. They had more safety. They challenged each other. They had team spirit, etc. So, we've known this for years. Menzies was a psychologist writing in the 1950s. Again, I think Nigel spoke about her last year when he was speaking about cultural problems in the NHS. And right from the 1950s, her work still resonates. She talks about the fact that healthcare, with its intimations of death and mortality, has to carry something really particular at the heart of it. And if we don't understand that world, and we don't create a language and a safety net around that world, we have problems. And I see echoes of Menzies' work actually in Messenger, one of the most recent reports on leadership, talking about some of the things that continue to go wrong in our health service today. And he talks about checking and burdensome regulation, hierarchy, punitive approaches to mistake, and attributions of blame. I've just described how we can talk about blame. And I think that the problems of blame are at the heart of some of our problems with productivity. There are many, many theories. There are lots of opinions about productivity and the issues in the NHS. And can I repeat, there is an issue. But because we have this unsafe environment, and because every theory comes with a conscious or unconscious attribution of blame, not just attribution, we're not moving on. So, it's all about capital, the best economic argument in the world. There is, by the way, spoiler alert, I'm going to go through loads of theories, they're all partially right. That's one of our problems. It's all about capital. Yeah, it is. Who's to blame? The government. What should we do with the theory? Reject it. You can see where I'm going. It's all about digital. Similar. Oh, we reject that except for heroic AI, which will save us all. We know. Thank the Lord. So we tend to, on the whole, reject it. Really interesting one. It's all about junior staff. So as I started talking about AI, talking about productivity with people, people say, well, the thing is, we've got more junior workforce. We've got more junior workforce, and more experienced staff are leaving. And I thought, that's really interesting. So I went and spoke to my erudite colleagues, Lucina and Billy in the Nuffield, and said, is it? Is it all about that? Because I don't know, I can't find any research. Interesting, isn't it? And I think that's partly because, remember the one where we're all shouting at each other? I think people would go, oh, it's all about this, but nobody had done anything. So my colleagues did this. And we've released that today as our chart of the week, but in a more complex way. Isn't this interesting? We have more staff on the register for less than 1 year. These are nurses only, by the way. This is nurses band 5 to 7. On the chart of the week, you'll see it also for scientific and technical staff. But this shows those nursing staff who've been in their band for less than a year, band 5 to 7, compared to 2015 is up 11 percentage points. The number of people, NHS joiners in band 5 to 7, nursing staff, up 21 percentage point, an absolute increase you've got there. And NHS staff under 35 years old in nursing is up 6 percentage points. I think this is really interesting. What this is, though, is a set of figures that leads you to ask questions. I think it could lead you to a good news story. Young people, people new in band, people coming in, people joining us, a diverse workforce. But what it doesn't tell you is what to do. I think it could be a really fruitful place to start thinking productively about productivity and what all of this means. Because I don't know, I've just got that data. Complexity. That's the other thing. You go and talk on any ward, it's all about complexity. It's all about the fact that the people coming in are bringing more problems in as they come. Again, some research coming out, but very little. But we've done some. And what we can show is that at the moment, every patient, every week on acute wards is getting approximately 30 minutes more care per week, and that is per day, and that is predominantly from a healthcare assistant rather than from a registered nurse. You have a change. Please don't ask me a huge range of technical questions about this graph, but very wise people can answer them. The most important thing is you can look at it. You can understand some of this data in a calm place. But what happens is you look at that data in a febrile environment that we have at the moment, and you don't have that creative, positive, complex conversation. You have a, well, what does this mean, and what are you doing, and it's the patient. And it still becomes part of our defensive narrative rather than curious. It's all about the strikes. Well, we know we can talk about that. There's loads of analysis being done from people in this room, from ourselves. So obviously the problems we're in is doctors and nurses' fault. They're striking. That's got us nowhere. Everybody gets very angry. It's to do with length of stay. I've noticed the NHS quite like this one a lot. They like it in particular when they can analyse it and show it's to do with social care. We like that one because then we can go, well, it's to do with social care. It's their fault. I mean, we love our social care, but it starts to become othering. Again, it's part of a non-psychologically safe space where you go, it's that. Now, some length of stay issues are without a doubt due to issues to do with the lack of a proper funding settlement for social care. Without a doubt. But it's interesting how that becomes a theory that we have traction around so much. I'm not sure all the data demonstrates it's there. Really interesting one, the McDonaldization or the taskification of work. If you don't know about McDonaldization, have a look. But it's basically how you put it, taskify what you're doing. So I do this, Martin does that, Leonora does that. But who's holistically looking at the patient? A lot of data and conversation around primary care coming out about that as well. But everyone feels sort of implicated in that. Our policy taskifies, the way we work taskifies. How does that really add into productivity? It's really hard to engage with that conversation properly. Everybody feels a little bit scrutinized, so we probably reject it and don't really talk about it. And then the one that we talk about a lot as well, discretionary effort has gone. We hear that a lot. People are burnt out. There's very low morale. It's very hard to actually analyze that. We've probably used the staff survey, which I believe is out later this morning as well, a national analysis, to help us get a feel about staff. But on the whole, everybody just feels victimized by that theory. So it irritates us and we all feel misunderstood. So all of this remains work that we do by looking at the data. We look at the data from the ONS. We look at the quality adjustment. We argue, going back to my apples and pears, we argue about the data. And any of the theories that even have been put forward tend to be ones that are very data heavy. I would also argue that we only really are going to understand and be most productive if we do what good leaders do all the time, which is they get up and they walk around and they talk to people and they have encounter. You learn through encounter. You learn through being with people. That is how your data makes sense. I have no idea what that data means about young people in the health service. I'm really intrigued. I don't know what it means. But I know I wouldn't find out by doing more data analysis. I know some of the way I'd find out is because I'd go and walk and talk and listen. And Briody, who I talked about before, is an amazing anthropologist. She worked with General Motors in the 1980s, and she worked looking at what they thought that they'd brought in the Toyota lean manufacturing methodology to get them back up to speed. And they couldn't work out why they were having all the problems that they were having, because they still weren't Toyota. What was going wrong? And they had a big team that went in, and Briody was the anthropologist who was part of that team. And she basically concluded that they thought that they were doing Toyota. They thought that they were doing quality and innovation, but they really weren't. And I think that's why I have some problems with Toyota and the way we use it in certainly the NHS. We're not really doing it, if you really understand it, to be about quality. What she saw is there were huge strikes going on in GM, there was huge unrest going on, and she concludes that power politics and blame culture were at the root of lower productivity in GM. Interesting. So what do I think? I think we've got amazing data. We're sitting on amazing data, some of which we use and a lot of which we don't. As I said, it didn't take the incredible analysts in the Nuffield very long to pull together the data to explain to me those issues around band 5 to 7 nurses in the health service. But are we calmly looking at that? And are we calmly going out and seeing what people say as well and what people do? I'm really keen that we put data science together with ethnographic data and ethnographic experience and observation. That's the way I think we get a holistic picture of where we are. Paul Krugman, known to most people, everybody in this room, eminent economist, said, productivity isn't everything, but in the long run, it is almost everything. And I think by starting with my concern that I could go into a room and look useful and intelligent about productivity, I came to a different conclusion. Psychologically safe culture isn't everything, but in the long run, it probably is almost everything. So what do we have to do? Well, we have to find better ways of doing what we're doing. We have to find better ways of making it psychologically safe to discuss productivity. We have to understand our data in a really complex way to know what it is telling us and what it isn't. And that's things like the quality adjustment, etc. We really need to understand that in a calm and safe way. we have to collectively look at those theories. I could have gone on. You could have had to sit here for another hour and went through even more theories of productivity. But we have to bring them together. It's actually not that hard. We have to bring them together. We have to understand what that national framework is. And we have to really know what we're going to do about that and co-produce it. I think we need a productivity truce. I think we're all culpable for where we are today. If you're a Royal College, if you're a frontline clinician, if you're a chief exec, if you're a newly qualified, maybe not you, if you're a university, if you're the government, if you're the Treasury, we're all culpable. We all have to have a truce. We have to stop shouting. We have to stop blaming. We have to accept we've co-produced this situation we're in. And we then have to have a really interesting, curious conversation where we feel honest enough to say, this is what's going on, this is what's happening, and this is how I want to work with others to change the situation. Or we're never, ever going to have the ability to solve what is an essential issue. Martin's already talked a little bit, but coming through, I hope what I've said is some themes about trust, about openness, about relationships. These things are hard. These are the hard yards when you're in any leadership, any thought position. Actually producing data, talking about information is easy. Creating psychologically safe spaces or dealing with trust, openness, and relationship in relationship to something like productivity is really hard. But I think that's where we need to go. So thank you.
Thank you very much, Thea, for that incredibly thoughtful start to the event. For those of you who don't know me, I'm Sam Friedman. I'm a senior fellow at the Institute for Government. I'm quite daunted by this audience, being quite an interloper into this world of health policy. I've spent most of my career in education policy, but last year I did do a big report on this very topic of productivity for the Institute for Government. And I think we covered all of the theories that you mentioned, Thea, so I was pleased we hit all of them. We're going to come to the audience in about 20 minutes, so please do get your questions ready for Thea on this topic. Bit of time to prepare them, but I'm going to start by asking a few questions first. And I wanted to start with the budget yesterday. Jeremy Hunt obviously saw our agenda and decided to help set us up by proposing a productivity plan. I don't know what number of productivity plan we're on now, but it was a productivity plan. And I think I just wanted to get a sense of how you felt that fitted into your analysis of. I'm not sure why you need a microphone, but.
Why?
Your microphone is just having an issue.
Oh, my microphone's having an issue.
Just how what happened yesterday fitted in with the sort of what you were talking about today, because it felt, on one hand, he wasn't particularly blaming people, the way in the text sort of doesn't blame doctors and nurses, suggest they're being lazy or anything. It very much says that capital investment is an issue. But on the other hand, the proposals made were very much developed in a dark room in the Treasury without much consultation and are based on heroic assumptions, shall we say. So. So what did you make of that approach? Do you think it sort of was a progress from what you're talking about, or really more of the same?
I think you're right that it does this work now, people?
Yeah.
It wasn't particularly about blame. It was, though, I think more of the same fundamentally, because the heroic assumptions about digital and AI and what it can create at speed was not nested in a really co-produced piece of work. I wouldn't say, without a doubt, putting capital in it is a good thing to do. Making capital available to do good digital work is an excellent thing to do. So you can't say that's not good. my real concern about the announcement around the capital was where the revenue wraparound for that is. Because you don't open a box and go, here's the digital, and now we are transformed. It doesn't work like that. It works by a lot of people having to do a lot of culture and behaviour change and working with systems. So I'm not really sure how this productivity gain comes from purely in the investment of a capital amount. And I've seen other colleagues who've done some analysis overnight saying that, I mean, some of the data that it's based on is it's very unclear where the assumptions come from. That it wasn't shouting.
Well, there we go. That's a small improvement.
It wasn't shouting.
Take our blessings where we can get them. We're going to have an election this year. Obviously, the budget was very much had an election in mind, and one of the reasons why it's perhaps quite difficult to talk to politicians at the moment is because they're very much in election mode. But when we have it, if the polls are to be believed, there probably is going to be a change of government. And when you get a change of government, especially after a very long time, you do get a change in energy, in sort of interest levels, and there'll be new white papers, new legislation. There's sort of an opportunity to sort of come in with a new broom and not sort of have to defend everything that's happened over the last sort of few years. How can the sector use that kind of reset moment, assuming it happens, to do some of the things that you talked about towards the end of your talk?
Yeah, and I'm just thinking back to your first question as well. I feel that to really answer the question about how the Chancellor, put out the money for digital, etc., which wasn't shouting, you'd nevertheless need to go and talk to frontline clinicians and frontline managers. You need to say to them, it's my thing about learning through encounter. You need to understand how does that land? What do you feel? How will that change? What's really going on for you today? And are they the biggest productivity gains that you could be making, given all the actually under-researched areas that we've got? A new government of any political colour has an opportunity to try and reset the dial. And I do think there is a real opportunity for the NHS, social care, and its wider partners to itself reset the dial. To be able to, we know that politicians will be driven by a whole range of factors that we have to in some way ignore. And I think we have to say we are now up for a really thoughtful, really comprehensive, honest, psychologically safe discussion about what's going on with productivity and bringing our narrative together and being able to present that in a really coherent way. I think one of the frustrations at the moment is there's many different pieces of work, but as a sector, as a loose coalition, there isn't even in this room an absolutely clear ability for us to talk to politicians about, yes, there is a productivity issue, and these are the elements, and here is an element to do with young people, and this is what we believe we should do about it, this is what we are doing about it, etc., etc.
So give us a preview. Let's say that Wes Streeting is, 6 months' time, is the new Secretary of State, calls you in for a meeting as one of the senior people in the sector. What message are you trying to get across to him in that first conversation? What do you want him to start doing differently from what you've seen before?
I suppose a slightly trite answer that came to me, but is you really do have to listen twice as much as you speak. You really, really do. Don't get photographed outside hospitals only, please. Make your first visit to a community clinic. Try and avoid the tropes of hospitals being the focus of everything you look at. Slightly different. And about productivity, stop telling us we'll be Singapore. We won't. Just breaking news. And go and really listen, and go and be very intelligently piece together the debate. We'll help you. I'll help you. Don't assume you know.
That's on the point of help. That's really interesting, because when you're talking about psychological safety, I mean, there cannot be a less psychologically safe job than being a politician.
No.
If you say one word wrong, you've got 1,000 people on social, tens of thousands of people on social media waiting to pounce on you, and in the worst faith imaginable. You've got journalists looking to get at you at every point, an opposition party whose whole job is to make your life miserable. It's not surprising that they might not understand why other people might not be sort of willing to exist in that kind of world, because that is their world.
Yeah.
How do you that you want them to make it more psychologically safe for the sector? How does the sector make it more psychologically safe for them?
Yeah, it's a good point. And I do think it's incumbent on anybody in any leadership position, though, to understand their own stress and pressures on them, and then to make it psychologically safe for others to do that. That's why I said I think really good leaders of organisations in the health service create an umbrella where they say, I will deal with all this stuff. This is a place where we'll have an honest conversation. Thea, why do you only see, 4 cataracts in a session when your colleague Sam sees 8? Can we have a conversation? What is going on? How do we learn? You can create that safety locally. And I think it's right that I have partly a role to work with politicians to help them feel this is an okay place to explore, to be curious, to have encounter, to think about things. But I also think that they have to find a way of dealing with that to allow them to make intelligent, thoughtful, creative policy with others. I don't think it can be just an excuse.
And I think part of the issue, having spent time in education and now looking at health, is health. In health, the Secretary of State's powers and role sort of feel more bounded. They feel much more restricted because it's a much bigger sector. There are many more steps between the Secretary of State and anyone acting on the ground. There are fewer things that they're allowed to do in terms, the Secretary of State in education can set a national curriculum. The Secretary of State for Health can't say you need to do a hip operation that way, which is just as well. But it is a much more, and it's become more bounded in a way because of NHS England and their Lansley reforms. Do you think in a way that kind of frustration, that structure of the organisation is part of the reason why you get Secretaries of State sort of clinging onto life rafts whenever they see them, because they don't feel actually they have much power in this system?
I don't know. It would be really interesting to ask them. I think if you look at some of the history of the NHS, certainly health secretaries cling to what they can do. But the felt experience often of NHS leadership is of over-interference and getting very involved in the detail. We all know the stories of particular health secretaries who will have the A&E performance of every single trust in the country up on their wall and be on the phone on a Monday morning to those where the A&E performance doesn't look as though it's what they wish it to be. So I think it's a complicated question.
I guess there's a dissonance between, you kind of have all this information and you can have that sort of list up on your wall, but what can you actually do about it?
Well, it's the desire all the time to control what is actually something you can't control.
Exactly.
But being able to live with that and knowing what you're trying to do, which is create a framework in which people flourish and which systems do their best. And that tension between control and non-control is actually really important to understand it and to know how you're going to utilise that. And that's where you get the push and pull all the time through, I'm going to let these systems be free, I'm going to let these organisations be free. I didn't mean when you were free you should work like that. I didn't mean that sort of freedom. I meant different sort of.
You're not allowed to hire any diversity officers. I didn't mean that.
No, I didn't mean that sort of freedom. So I think there's a constant tension there. I think a mature political leader has the ability to manage that and deal with it.
So I wanted to get into this sort of question of the way the NHS works sort of below the level of politicians, because again, for coming from the education world, there's such a distinction. There aren't actually really any steps between the Secretary of State and now most schools. There's a trust that runs the school, and then there's a Secretary of State. That's it. Whereas, of course, in health, you have NHS England, you have ICSs, you have ICBs and ICPs and all of these acronyms. It's very complicated and very hierarchical to someone coming in and sort of looking at it. Is that part of the problem? Is there a sort of, I imagine that the sort of last thing people want is another restructure of the NHS.
No.
But sort of, is there something there in terms of thinking about the way that structure operates that's making it harder or creating barriers to having the conversation that you want?
No. I strongly believe that you can make most structures operate well with, it depends on the people, the attitudes, the behaviours within that. You can create, I have no idea if the structure we've got in the NHS at the moment is right or wrong. I really don't. You could make arguments both ways. What I do think is that you can show it where you've got DHSC, you've got an NHS England, in enabling, supportive, facilitating role. You've got the clinician at the top of an organogram, actually probably the patient at the top of the organogram, and you've got everything else enabling, facilitating the best possible quality of care. I think you can make the system you've got work well, you can make the system you've got fail.
What about within the level of sort of individual trust? Because I got interested in this topic. I've always been interested in the topic, but I thought I'm actually going to make the effort and do sort of months of research to understand the sector better. Because I was a patient, I spent 4 weeks in hospital a couple of years ago, and being a sort of policy wonk, I didn't just lie there. I sort of poked around and tried to figure out what's going on and why everyone seems so frustrated, actually. And I sat there and watched the junior doctor sit on their computer, which didn't load, taking hours and hours to book appointments for X-rays and so on across the hospital, which could have taken minutes. I saw the nurses having to run around constantly changing the plugs on all the sockets because there weren't enough chargers for all the machines, which, just enormous waste of time. And I made a set of assumptions about that. I thought that was because they couldn't do a lot of things. They weren't empowered to do a lot of things, technically weren't allowed to do a lot of those things. And then when I went to talk to the hospital management when I was doing the report, they said they actually are allowed to buy more chargers. There's nothing stopping them buying more chargers. They just don't. And so this sort of question of trust that you're talking about and psychological safety, it seems to go all the way down, right, to the level of sort of individual staff working on wards not feeling they can even use the powers they have to make the kind of small productivity improvements that would add up to a lot.
Yeah. I bet you were a great patient.
I was an incredibly annoying patient.
I can just imagine you in the ward.
Me just wandering around.
Writing your notes all the time.
Exactly.
You're right. You're absolutely right. And it's really, really interesting. It's really interesting how stuck certain parts can be, right at the clinical front line. You always have to be very aware if you're a chief exec that you think you've made some grand pronouncement about, everybody can buy chargers. There shall be no problem with charger buying. And you can be sure that you will go on a walk around in 10 days' time. People will say, we're not allowed to buy. We're not allowed. It's absolutely awful. We just can't. And unpicking that is really important. I mean, it's one of the things that Briody did, anthropologists do ethnographically, is spend time really, really working out, why do those nurses on that ward think they can't buy chargers? It's what she did in GM when they said, go in and solve our productivity problem. And there's some fascinating stories which I won't bore you with, but there are detailed ways of understanding why is the culture stuck like that and what can you do to change it. You can do it, but it's not using all the same tools that we use in the same ways. But it's hard. And
combining that kind of research with the technical data-driven research just doesn't happen very often. You have these different worlds doing this research.
And that's why you can end up with a pronouncement yesterday, which I'm not going, it's all dreadful. Of course it's not. For technical, digital innovation and AI that will solve the world and productivity. And you can be in hospital bed seeing somebody who doesn't have enough chargers and trying to work out really how is that going together and really how is it going to work and change. And you have to understand it all.
On that note, I'm going to go out to the audience and ask for questions. We've got one hand up, loads of hands as well. I'm going to go to this gentleman here and then this lady here, but we'll start.
Can I just ask, do I have to keep using this now or can I use this?
I think
Use
you need
this.
to keep using that.
Yeah, okay.
Please, can you just say who you are and where you're from?
Sam Everington, GP in Tower Hamlets, also previously a CCG chair and on the board of a mental health trust in East London. Your issue about productivity, one of the things we did in those 10 years as a CCG was literally pay for a phlebotomist in every general practice. Actually, an incredibly small sum of money. But what it did was upskill all the GPs, supported and enabled virtual wards to keep patients out of hospitals, and then supported advice and guidance. So up to 65% of our referrals are done with advice and guidance within a week, no patient having to wait for months on a waiting list to go to hospital. So an example of productivity. But to do that, you need QI investment. So we invested $600,000 a year in quality improvement. And as commissioners, we used our power to shift funding. So I've got 3 questions, all part of the same question, is what's your view about the balance between performance management, regulation, and quality improvement? What percentage of a budget in any system should go on quality improvement? And how do we get ICBs to use their muscle around productivity, or what I would label it as just improving patient care?
I don't know. I don't know the balance between the quality improvement, the regulation. I tend to think that quality improvement drives change more than sort of top-down regulation or performance management. I don't think that has been demonstrated particularly to be effective, but all 3 are clearly important. ICBs, I've spoken to a couple of ICBs and ICSs around thinking about productivity and looking at the theories. What I find interesting is, apart from one, the actual really detailed analysis of what's going on in productivity in our area. And I mean, I didn't even talk about the fact that most of the data we use for productivity analysis anyway doesn't include primary care, which you'll be more than aware of. So the national data doesn't take a lot of notice of a whole load of the primary care data. ICBs will where the right people have got the right relationships with the right individuals with the right attitude, they use their convening power to bring the right conversation together. And that's where I think ICSs can work, and ICBs, they are conveners. They are conveners of a good conversation in what I hope is a safe place to understand what it is that they can do. They've got the power to do that if they want to. Some do.
I had a question on this table.
Thanks very much. Crystal Oldman, and I'm the Chief Executive of the Queen's Nursing Institute. I have a great presentation. Thank you so much for including community and including relationships. And health work, social care work is relational. It's human work. It's really good to hear the emphasis on that. So yesterday, a bit of a heart-sink moment around productivity and digital for nurses in the community and in social care with, as you said, this is not going to solve everything. So my question is about the suggestion of encounters. I think that is absolutely brilliant. One of the things we've been doing at the Q&I is to offer almost like a secret shopper for senior politicians, senior policy advisors to come and spend time with a nurse in patients' homes. See what it looks like, spend a day. And the impact is enormous. And I think you were referring to this here, seeing work as done rather than work as imagined. And one example so my question is about how we make this more intentional and not random. How does it, because we're doing this randomly. We're asking all of our Queen's nurses, ask your local MP to come and spend a day with you so they understand the health and the social care service. And an example that I've got is that senior health advisor of a previous Secretary of State, not so long ago, came out to spend a day with a district nurse and started the day with saying, it's all about productivity, it's all about digital, we're going to transform community. My boss thinks we're going to transform community. And at the end of the day, he said, it's not going to work. It's absolutely not going to work, and I'm going to take this back to head office and say it's not. We've got 10-year-old hardware, we've got software that doesn't speak to each other, and what's more, this is more about relationships with patients, it's not about the digital. But it's also that message that's not going to solve the problems of the health and social care service. So my question really is about how we make this more intentional, how we get policymakers to have honest encounters, not the red carpet encounters. Thank you.
Yeah, I mean, as you said, Crystal, it's always amazing when you bring people out and you put them particularly in people's homes where they still think the whole world's, call the midwife, and it actually has moved on rather a lot. And so bringing people out and allowing them to have honest encounter, I think, is absolutely crucial. I think it behoves us. It's with Sam's challenge to us as well. I think it behoves us as a community to be intentional and to be thoughtful about how we are answering the productivity questions and bringing proper answers, how we're dealing with we're going to have a really good session, I hope, later on AI, how we're dealing with some of the fantasy around AI and digital without some of the real nuts and bolts around it. I think we need to have a much clearer narrative collectively.
If someone could take David Frost to a hospital at some point and or community clinic and explain to him how the NHS works, that would be great. Just a question over there.
Hi, Sean Linton from the Sunday Times. Just embracing the idea of psychological safety at this summit. So, yeah, I just wanted to zero in slightly on the issue of quality of management in the NHS. And, Mary Dixon Woods talks a lot about the processes that we have in the NHS and how we don't have a very good idea of what those processes are, how they should work. We don't have an industrialisation approach to that, and we're quite poor in the NHS. And so we have poor managers doing poor things, and they don't know how to improve. I, as a journalist, speak to lots of people who tell me all the time that they're working with people who they think should be sacked, that they shouldn't be there. And yet the NHS seems to find it quite difficult to get rid of those people. They're promoted upwards or sideways, and they continue to cause trouble elsewhere, and that's something we see all the time. So there's that side of it. Then flipping the coin the other way, when is the NHS going to start standing up for good management and start tackling the kind of right-wing media approach that we have too many lazy managers and the NHS is overmanaged, when actually we all know it's got a paucity of good management? So I'd just be interested to hear your thoughts on that.
Well, I mean, obviously on the latter point, Sean, particularly my colleagues from Confed and providers who are in this audience do an awful lot of standing up for good managers and talking about good leadership. The Nuffield and all other think tanks have regularly said the NHS is undermanaged, the NHS is not overmanaged. You need to have a real positivity towards what management and leadership is, understand the complexity of the job and support people well. So I think there are a lot of voices around it. I think actually it goes back to my curiosity, which is that I think there's a lot of voices and there's a lot of evidence put out there, but it's rejected because there's a prevailing narrative which is often, the hero doctor, the angel nurse, the bad manager. It's very pantomime. And we like that narrative somehow as a society. It's sticky. And the alternative narratives, we keep trying to change the narratives and they don't stick. And that's where I think we need to have a really, you asked me with Wed Streeting, have a really thoughtful conversation about why is that narrative not sticking? When's a politician going to stand up and say, the reason this was solved, the reason this was brilliant was because leadership and management was outstanding and creative and brilliant. In terms of, does the NHS, find it hard to move people on? Does the NHS find? Yeah, absolutely. Absolutely. There's real challenges and real complexity about how I think the NHS, local government as well, but the NHS in particular, finds often it really difficult to manage and lead well But again, we need to really understand. How many times have we heard people go for soft targets by looking at HR or OD or people management? I mean, that again is something that happens a lot. But yeah, the NHS isn't particularly brilliant at it.
I'm going to go towards the back of the room now. There's a gentleman on that table on this side over here.
How long have we got?
Another 10 minutes.
Oh, really? Okay. Please stand there.
Alex Fox from Empower Consulting, and I'm a member of the NHS Assembly. I found your relational view of productivity really compelling, and I wondered if we could push that even further, with most social care being produced by families rather than the state, and arguably all health and well-being being a collaboration between services and people and families and sometimes communities. Do we need an idea of productivity that actually looks at what we all produce, what citizens, families produce, not just what services produce, and kind of really extend that idea of a relational view of productivity?
Yeah, I really like that, Alex. I think you're right. It is really interesting, and we know it's very much part of the any analysis that we do about unpaid carers and family support. You know, there's been a myriad pieces of work looking at the productivity gain, really, of having this huge army of unpaid carers, of having family support for people. And we know that that's regularly presented to the Treasury, to ministers, to demonstrate the need for more support. It doesn't read across to more support. It probably reads across as in, well, that's good then, isn't it? Because we get all this free care. But you're absolutely right. We are co-producing this care, this productivity through relation and through family all the time.
So a lady in the red top right in the middle.
Two people in the red. I'm going to defer to this lady. She had her hand up.
Oh, I feel that's a prime example of relational approaches, particularly as I'm about to fly the flag for social care. So my name is Liz Jones, and I'm the Policy Director at the National Care Forum, and we're a membership organisation for not-for-profit providers of care and support. And the point about being not-for-profit is actually quite important in the thing I'm about to say. So I absolutely loved your presentation about the productivity puzzle and that focus on the relational rather than the rational and to some extent the contractual. So I think that certainly the members I support who range from very big organisations running enormous ranges of services, a portfolio of services supporting thousands of people across the country and employing thousands more, they have a huge amount to offer in this productivity debate. But to be able to be in that debate, they have to get into the room. And getting into the room in local systems is incredibly difficult. And your point about the kind of pantomime narrative of bad doctors, bad nurses, I would say there's a subliminal ideology that social care providers are not necessarily in it for the best intentions. And if you start with the not-for-profit sector to begin with, you can take away some of that ideological challenge. But to be able to be part of the solution and that co-productivity truth that you talked about, that I think is really important, particularly also from Crystal's examples, we've got to get in there and be seen as strategic partners, strategic leaders in our localities. And there's loads of people in this room who can make that happen. So I guess my question to you is, what else do we need to do as a sector, and what else do we need our partners across local systems to do to get us into that debate so we can bring, particularly from a social care perspective, much more around early intervention, prevention, helping people to live their best lives, so they need to have minimal interaction, actually, with the health services that can support them. Thank you.
So, yeah, no, I agree. I think that, so if we go back to Briody and sort of anthropology and indeed other areas I talked about language, To be in the room, I think whilst I may be asking for a change in language, there is a predominant language. There is a predominant language and a predominant way of talking. To be in the room, you need data. So to be in the room, you need the data from which you will have, the data, the financial analysis, the information, and that is how you get in the room. And having worked in a system where we did bring the type of provider you're talking about into the room. Your passport into the room, this isn't a relational space. It is a space that cares about data, narrative, financial. And getting into the room, that's your passport in. I know you know this. I know you don't not know it. And those are our passports in. I may describe the languages and describe a change. But if I want to be in that room, and you've got to have the data to get into the room, and you've got to have the analysis to get into the room, and it's got to be credible. But then I think you get in the room.
The lady who nicely handed the mic over before should get her turn and ask her question.
Thank you very much. I can't sing like Beyonce, but I will try. Anne-Marie Rafferty, I'm a nurse academic from King's College London. Oh, could I stand? Okay, yeah. I loved your presentation. So my question really was about the definition and the meaning that productivity has to different, I suppose, stakeholders in the NHS, because you talk about data, that kind of compresses the meaning to a particular sort of number, and it's just too clunky and inflexible to be able to accommodate the relational. Somehow, we can't see these things as polarities. We've got to do both and. So I wondered how can we stretch the meaning of productivity so that it has much more elasticity and can actually boundary span between the numbers and the kind of narrative meaning that many people attach to it.
Yeah, and I guess I'm not an economist, I'm sure you're all more than aware of that, and the understanding of how econometric data is used to come up with the productivity answers that the government has, I think, again, my starting point is as yours, we have to, and that is the language, that's the prevailing language. But then how do we use that language and bring other conversation into the room? And that's where my grid, which is data analysis, using evidence, but encounter, have to be seen as a parity of esteem. Doing proper, in-depth, ethnographic work, this isn't fluffy nonsense. This is really important, structured work, and that needs to be alongside and utilised in the same way as the data, so that we are presenting to ministers, to others, this is the way we understand productivity. This is how we're nesting the data, how we're using the data. I think that what happens, because people come from a relational background, a relational understanding, which I would posit many people do from service, that they come into a room with the data and then they start arguing about the data. Because it's actually the response to the feeling of, this doesn't reflect my world, this isn't where I am, this isn't what reality feels like. So actually, you end up in a conversation doing the apple, pears, and tangerine conversation, whereas actually, it may be the data's actually right, but it's not situated in that richness of experience, which is what will make the person coming into the room go, yes, I see that, I don't know, the length of stay for stroke patients and its transfer into community services isn't happening fast enough. And I understand from talking to the community service that this is because of this experience, this level of what's happened, this trauma that happened in this team. So then, that full information means the community team can engage with the data and go, yeah, you're right, we're not taking people quickly enough because you see all of me. Because we don't present it, you go into the room and you argue. She says, speaking from personal experience.
There's a man just here at the front.
Hi, thank you. Steve Ford, I'm Chief Exec at the Royal College of Occupational Therapists. Thanks, Taya, for that great presentation. I was a chief exec in the NHS for, well, not a chief exec, general manager, chief exec in the NHS for about 20 years, and so recognised that defensive bit about productivity. And I think because of that, I was a crap chief exec. I went to work for a patient organisation then for 15 years, and I so wish my career had been the other way around. If I had worked in that patient organisation first before going into that leadership role, I think it would have been very different. And so I suppose I'm just curious, there hasn't been much conversation today about patients and patient experience. And I think, now as I get older and as I get a consumer, I just recognise how valuable my own experience is. Last week, you have 2 sleepless nights worrying about a genetic test. You go to a clinic, you ask the doctor, oh, I haven't got the results of that test. So for the next 4 or 5 days, people are frantically running around trying to find it. So it's my experience, but it's also a massive productivity issue. And how does that get kind of played in, I suppose? And so I'm just wondering, when we talk about productivity, how can we reframe that around patient experience, patient delay, patient fear, patient anxiety, doing things twice, doing things 3 times? And if we did that, would that kind of engage clinicians? Would that engage a common dialogue? I recognise, and I'm not arguing for 1 minute, that we should introduce market forces and competition into the health service. But Tesco's and Sainsbury's, if they were sitting here today, wouldn't be talking about productivity in any way near similar way to what we're talking about. It's, how do we improve our car parking? How do we decrease the price of our yogurt? How can we provide better customer care? And so, we're set up in a way that just avoids having, I think, the real conversations we should be having.
I agree. As you saw, I went down quite a lot of rabbit holes with Briodi because I've been quite interested in her work. And she works, as I say, as an anthropologist in America. And she writes a paper which I found really interesting when she first got approached by an American healthcare system. We all know how very different they are. But the American healthcare system said to her, will you come and help us become more patient-focused? And she writes about, she was like, what? Why are you not patient-focused? How are you coming and asking me to... She'd never worked in the health service. She was like, what? And she was like, I don't understand. I don't understand. What do you mean you want me to help you become more patient-focused? And she talks about going, and because she's an anthropologist, and she spends a day in outpatients. Then she understands. Then she knows, oh, yeah, I see what you mean. This organisation is running for the staff. This organisation is not running for the patients. And you're absolutely right, Steve. I think there are enormously powerful events, which you've done we've all done, I think, many of us done, where you bring together a patient story, a patient experience, regularly with clinicians, with managers, and go, this is what it's like to wait in this waiting room when you're blind. This is what it's like to walk these wards, et cetera, et cetera. When you're a patient. And there is, again, something where you put the idea of patient-centeredness at the heart of productivity, you get a different story and a different conversation going. The problem is the narrative feels soft to people. The narrative doesn't feel like data. And data is king. So we have to find a way of bringing it together.
And it goes to sort of equality as well, that point around patient experience. I mean, my experiences as a patient, I spent many hours waiting in outpatient waiting rooms, and because I'm impatient and annoying and middle class, I was able to figure out that I could ask for the doctor I wanted rather than just be assigned to one. But most people just get assigned to one. So that creates then an inequality in patient experience as well as a productivity issue. I'm going to take one more question before we wrap up. Lady right in the middle there with her hand up still, yeah.
Bola Olabi, NHS England. And Taya, thank you so much for an excellent speech. Relational leadership. How would you create headroom to develop relational leadership skills in a transactional system?
Good one to end on.
I come from a particular background and a way of working, and I can recognise colleagues in the audience who do as well. I think if you don't make it, because it's essential, because it's a people business. You know, it's a people business. What we are is NHS and social care is a business full of people serving people. And we still haven't got some of the basics as right as a supermarket. We aren't somehow recognising ourselves as part of a relational business. So I think we have to make space, but I also think we have to very consciously change the language. We have to change the language that allows that space to be there, and we have to, right from the top, from NHS England, from DHSC, from ministers, we have to be asking questions that make people know that this system's interested in this conversation. This system is interested in understanding and wants to solve the productivity question through a new discourse. And that's just got to be at every level.
Feels like a very good note on which to end what I hope you all agree has been a fascinating and thought-provoking initial session to the conference. So please join me in saying thank you to Thea.